So today we study tumors. This is first lecture about tumor. Today we are talking about nomenclature, etiology, carcinogenesis, morphogenesis, metastasis, growth and structure of benign and malignant tumors, and tumors of epithelial origin. So we discuss few issues. A definition of neoplasia, carcinogenesis, etiology and pathogenesis of neoplasia, abnormalities in growth, some definitions of benign and malignant tumors, pre-neoplastic conditions, gross picture of a tumor and microscopic peculiarities, nomenclature of tumors, and some aspects of tumors of glandular epithelium. So you must know that cancer nowadays is the second leading cause of death after cardiovascular diseases and stroke in industrial countries. Most common tumors types in men and women. In men, they are lung, prostate, colon, rectum. In women, breast, colon and rectum, and lung. The influence of environment is very important. For example, we have the case that offspring of Japanese migrants to Hawaii exhibited a decreased incidence of stomach cancer and also an increased incidence of cancer of breast, colon, and prostate. Also, they have increased incidence of Hodgkin's disease. The incidence of nasopharyngeal carcinoma decreased in the offspring of migrants to the United States from China. Eastern Europeans who migrated to the United States showed an increased incidence of carcinoma of the breast, colon, and prostate. Finally, the incidence of Burkitt's lymphoma changed in Africans who migrated from Central Highlands to coastal lowlands or to the United States. What is neoplasia? Neoplasia means new growth. The new growth produced is called neoplasm or tumor. New growth of tissues and cells also exist in processes of embryogenesis, regeneration, repair, hyperplasia, and hormonal stimulation. But with neoplastic cells, it is quite different. Neoplastic cells lose control and regulation of replication and form an abnormal mass of tissue. So, neoplasia is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissues and persists in the same excessive manner after cessation of the stimuli which evolve the change. The suffix "oma" is added to denote tumors. Malignant tumors of epithelial origin are called carcinomas, while malignant mesenchymal tumors are named sarcomas. Sarcos means fleshy. Carcinogenesis means induction of tumors. Agents which can induce tumors are called carcinogens. Carcinogens are divided into 4 groups: chemical ones, physical, mainly radiation, hormonal, and viral carcinogens. So a few words about etiology and pathogenesis of neoplasia. Virogenetic theory, it states integration of the genomes of virus and the normal cell, which turns into tumor cells. Oncogenic viruses are those containing DNA and RNA. They are different and they all can stimulate neoplasia. Physical and chemical factors describe physicochemical theory. It suggests that tumor appears under influence of different physical and chemical substances, so-called carcinogens. The third way, dysontogenetic theory, was created by Conhay. According to this theory, tumors appear from embryonic tissue and abnormally developed tissues under the influence of different causative agents. Polyetiological theory emphasizes the importance of different factors like chemical, physical, viral, parasite, and dyshormonal ones. So what is it, the abnormalities in growth? So we can see alteration in number of cells in case of hyperplasia, increase in mass of tissue or organ because of cellular increase beyond normal range. Alteration in cell composition and maturation. We have various pathologies like metaplasia, acquired change of tissue or organ because of change of one adult cell type to different adult cell type. Dysplasia, it is abnormal sequence of changes in maturation or development of cell type in a tissue or organ. So, as we said before, neoplasia is the formation of new growth by abnormal cell proliferation. Here you see the schematic illustration to show the molecular basis of cancer. So various carcinogens like chemical ones, radiation, viruses, may cause the DNA damage of the normal cell, and the genes affecting apoptosis may cause cell mutation, activation of oncogenes and inactivation of anti-oncogenes, and also the affect the injury of apoptotic regulating genes. All these causes may result in cancer cell formation. And then after that, we have the clonal expansion, tumor progression, and at the end, we have the full malignant tumor. So what is it, cancer progression and heterogeneity? So clonal aggressiveness. So you must remember that is a very important issue. Cancers, with passage of time, become more aggressive. This property is termed tumor progression. Clinical parameters of cancer progression are increasing size of the tumor, higher histologic grade, as seen by poorer differentiation and greater anaplasia, areas of tumor necrosis, so tumor outgrows its blood supply, invasiveness, and distant metastasis. So with time, any kind of cancer becomes more and more aggressive. And this property we name progression of the cancer. So look at this picture that describes the tumor progression. So for example, you see the single tumor cells in the lung. Here, normal cell, and then after transformation event, we have the single tumor cell, and then starts progression. So 30 doublings, and we have 1 gram of the tumor. And so here, this is the smallest clinically detectable mass of the tumor. But also, it can cause microscopic metastasis. And then we see tumor cells divisions. So, and with any division, with every division, we have proliferation of genetically unstable cells. And due to that, we have tumor cell variants. So some of them were good in invasive properties, the other metastatic, the third one, various other properties. So we have various kinds of tumor cells. So, and we see also with every division, the clonal expansion of surviving cells variants. So it helps to survive the tumor. And after other 10 doublings, we have 1 kilogram of a tumor. That is maximum mass compatible with life of the patient. And also we have distant metastasis. In tumor, we have immune responses. We have cell-mediated mechanism, humoral mechanism, inhibitory regulatory mechanism. Cell-mediated mechanism, this is the main mechanism of destruction of tumor cells by the host. The following cellular responses can destroy the tumor cells and induce tumor immunity in humans, like specifically sensitized cytotoxic T lymphocyte, CTL, natural killer cells and CAR cells, which are lymphocytes which destroy tumor cells without sensitization, either directly or by antibody-dependent cellular cytotoxicity. They are the first line of defense against tumor cells. Also, we have macrophages, which are activated by interferon Y secreted by T cells and natural killer cells, and therefore there is close collaboration of these lymphocytes with macrophages. Activated macrophages mediate cytotoxicity by production of oxygen-free radicals or by tumor necrosis factor. Also in tumor, we have a humoral mechanism. Humoral antibodies may act by complement activation or by antibody-dependent cytotoxicity, but by natural killer cells. Inhibitory or regulatory mechanism. During progression of the cancer, immunogenic cells may disappear. Cytotoxic T cell and NK cells may play a self-regulatory role. Immunosuppression mediated by various acquired carcinogenic agents like viruses, chemicals, and radiation, for example. Immunoinhibitory role of factors secreted by tumors also play a role, for example, transforming growth factor. So here are the schematic illustration of immune responses in cancer. So you see here cytotoxic T lymphocyte, natural killer cells, antibody-dependent cellular cytotoxicity. So all mechanisms are involved in immune response to cancer. So various tumors have macroscopic features, microscopic features, growth rate, and local invasion, direct spread or metastasis, distance spread. We divide all tumors into benign and malignant tumors categories. So benign tumors, we call also them differentiated. So they are fewer tumors. So benign tumors resemble their parent tissue, both histologically and cytologically. They do not invade adjacent tissue and metastasize. Malignant tumor, also called undifferentiated tumors, depart from the parent tissue both morphologically and functionally. They invade adjacent tissues and also they have metastasis properties. So look, here we see the sequence of events in the invasion of epithelial basement membranes by tumor cells. At the beginning, tumor cells detach from each other because of reduced of adhesiveness. You see here one cell with no attachment with neighboring cells. Here you see basement membranes and various collagens of the connective tissue. Here you see cadherins, which can help to support the adhesiveness to the various neighboring cells. And when this cell has no connection with the neighboring cells, these cells then attach to the basement membrane via laminin receptors. Here you see the laminin receptors. Then we see the beginning of the production or synthesis of collagenase, also plasminogen activator, and we see the beginning of the degradation of the basement membrane and the beginning of the cell migration via basement membrane. Here you see the next stage. You see autocrine motility factor production, so it helps to move the cells through the basement membrane. And also you see the connection of the cells with fibronectin, and all that helps tumor cell migration. So here you see the schematic presentation of various stages of the tumor. You see here the A stage, when the tumor grows only within the mucosa. We see the no metastasis to lymph nodes. Then BA, you see the growth through the epithelial layer, and then other layers beneath the epithelium through the connective tissue, but within the wall of the organ, for example, rectum. So, but then you see the extent of the invasion, and at the end we see, at stage C, we see lymph nodes metastasis and distant visceral metastasis, so to other organs, and stage D. So step by step we see the growth of the cancer, with local and distant metastasis at the end. You must remember the difference between benign, as I said before, differentiated tumors and malignant ones. So usually benign tumors are encapsulated or well circumscribed. Malignant tumors poorly circumscribed and irregular boundary. Surrounding tissues often compressed by benign tumor, and in case of malignant tumor, usually invaded. The size of benign tumor usually small, malignant often larger. Secondary changes occur less often, and in case of malignant changes occur more often. What are secondary changes? Secondary changes are hemorrhages, necrosis, and inflammation of the tumor tissue and tumors next to them. Here you see the stomach mucosa. You see stomach, gross microspecimen of the stomach, and here you see on the small curvative of the stomach a protruding formation on the wide base with a slightly villous surface, which is quite visible in stomach mucosa. It is a polyp. Polyp is a benign neoplasm, but sometimes it is not a neoplasm at all. It is the inflammatory polyp, as you must remember from the previous classes of chronic inflammation. Here you see the cancer, stomach cancer, the gross microspecimen of the stomach, and in the stomach mucosa you see quite large saucer-shaped stomach, protruding above the surface of the mucous membrane. The cancer has a wide base with raised, dense, roller-like edges and sinking bottom. The bottom is covered with gray-brown decaying masses. So there are secondary changes in this particular carcinoma. Here you see also stomach gross specimen in mucosa. You see multiple benign edematous gastric polyps. And here, this particular gross specimen was the incidental postmortem finding. Polypoid adenocarcinoma of the stomach. The patient was treated by partial gastrectomy. See here, mucosa, gastric mucosa, and here the mass of the polypoid like adenocarcinoma of the stomach. Here you see the example of the secondary changes, adenocarcinoma with ulceration. So this particular patient was treated by partial gastrectomy. You must remember about morphological atypia of tumor. Tissue atypia. Morphological alteration of tissue of origin. We can see tissue atypia in case of benign and malignant tumors. Cellular atypia or anaplasia. Malignant tumors may have variation in size and shape of cells and cell nuclei. We call it pleomorphism. We see enlarged and hyperchromatic nuclei. We see atypical mitosis, and bizarre cells which present also anaplasia. So please look at this picture. On the left part of the picture, you see the example of benign epithelial tumor of breast. On the right, we see the malignant one tumor. So here, you see encapsulated tumor on the left, and we can think that probably it is benign. On the right, we see diffusely infiltrated tumor, which is usual for carcinoma. Then, under microscope, we take a piece of tissue to study under microscope. And under microscope, we see only tissue atypia. Tissue atypia, it means the tissue architecture a little bit different from the normal one. But cells are the same as in normal situation. No change in size, the pattern, no changes in connective tissue pattern, no changes in nucleus. But if you look on the right side of the picture, you see stromal invasion, intraductal anaplastic cells, and look, the cells are bigger, they have bigger nuclei with the darker coloring due to hyperchromasia or more hyperchromic nuclei, which are the examples of carcinoma. So anaplasia is a lack of differentiation and is characteristic feature of most malignant tumors. Depending upon the degree of differentiation, the extent of anaplasia is also variable. Poor differentiated malignant tumors have high degree of anaplasia. As a result of anaplasia, noticeable morphological and functional alterations in neoplastic cells are also observed. Here, look, you see so-called signet ring carcinoma of the stomach. So this is histological slide of the stomach tissue wall. And you see atypical cells, and some of them resemble a ring. The nucleus is displaced to the cell membrane, which encloses a translucent cytoplasm filled with secretion, here the number 1. And we see it really looks like a ring with a stone. There are atypical cells with a very large irregularity shaped hyperchromic nuclei. So you see, look here, various shapes of the nuclei, and all of them hyperchromic, so darker than normal. And really, you can't find two absolutely similar cells and nuclei. They are all different. We call this polymorphism. Here, we see the invasive adenocarcinoma of the colon, and we see malignant glands infiltrating the muscle wall. So the examples of anaplasia, we see loss of polarity. So what is it, loss of polarity? Normally, the nuclei of epithelial cells are orientated along basement membrane, which is termed as basal polarity. This property is based on cell adhesion molecules, particularly selectins. In early malignancy, tumor cells lose their basal polarity so that the nuclei tend to lie away from the basement membrane. The other feature of the tumor, pleomorphism. The term pleomorphism means variation in size and shape of the tumor cells. The extent of cellular pleomorphism generally correlates with the degree of anaplasia. Tumor cells are often bigger than normal, but in some tumors they can be of normal size or even smaller than normal. Also pay attention of nuclear to cytoplasm ratio. Generally, the nuclei of malignant tumor cells show more conspicuous changes. Nuclei are enlarged, and this enlargement is disproportionate to the cell size, so the nuclear cytoplasmic ratio is increased from normal 1:5 to 1:1. Anesonucleosis, another characteristic feature. Just like cellular pleomorphism, the nuclei too show variation in size and shape in malignant tumor cells. Hyperchromatism. The nuclear chromatin of malignant cells is increased and coarsely clumped. This is due to increase in the amount of nuclear protein, resulting in dark staining nuclei, referred to as hyperchromatism. Nucleolar changes. Malignant cells frequently have a prominent nucleolus or nucleoli in the nucleus, reflecting increased nuclear protein synthesis. That is very important diagnostic feature for malignancy. Mitotic figures, also important feature. The parenchymal cells of poorly differentiated tumors often show large number of mitoses as compared with benign tumors and well-differentiated malignant tumors. These appear as either normal or abnormal mitotic figures. Normal mitotic figures may be seen in some non-neoplastic proliferating cells, for example, hematopoietic cells of the bone marrow, intestinal epithelium, hepatocytes. In certain benign tumors and some low-grade malignant tumors, we also see some mitotic figures. In sections, they are seen as a dark band of dividing chromatin and two poles of the nuclear spangle. Abnormal or atypical mitotic figures. They are more important than usual mitotic figures. They are identified as tripolar, quadripolar, or multipolar spindles in malignant tumor cells. That is very important feature of malignancy. Tumor giant cells, multinucleate tumor giant cells or giant cells containing a single large and bizarre nucleus possessing nuclear characters of the adjacent tumor cells are another important feature of anaplasia in malignant tumors. Functional or cytoplasmic changes. Structural anaplasia in tumors is accompanied with functional anaplasia as appreciated from the cytoplasmic constituents of the tumor cells. The functional abnormality in neoplasm may be quantitative, qualitative, or both features. Here, look, we see in this picture the difference between normal morphology of the glandular cells, for example, we see the gland, normal one, on the left side, and on the right side we see the cancer. So here, the basal polarity. So you see the line of the nuclear close to basal membrane. On the right side, we see loss of basal polarity. So you see some nuclei closer to basal membrane, the other ones not. So various location of the nucleus in the within the cell. Also, we see pleomorphism. So various forms, all cells are different. Also, you see increased N to C ratio. It means nuclear area bigger than in case of normal cell. So nuclear ratio to cytoplasm is also increases. You see here anesonucleosis, nuclear hyperchromatism, prominent nucleoli. Also we see abnormal mitotic features. Sometimes we see giant tumor cells with many tiny nuclei, sometimes increased mucin, and also we can recognize DNA aneuploidy. Here in this picture you see benign tumor adenoid. So we see a lot of follicle with colloid, but their cells are similar to each other, and so they are also some glands normal looking. It means well differentiated. We only have tissue abnormality in this particular case, and no cell atypia. The other picture is malignant tumor adenocarcinoma of the colon. Note that they compared with the well-formed and normal-looking glands characteristic of a benign tumor. The cancerous glands are regular in shape and size and do not resemble the normal colonic glands. This tumor is considered differentiated because gland formation can be seen. We see some sort of glands. The malignant glands have invaded the muscular layer of the colon. Anaplastic tumor of the skeletal muscle, rhabdomyosarcoma. Note the marked cellular nuclear pleomorphism, hyperchromatic nuclei, and tumor giant cells. Anaplastic tumor showing cellular nuclear variation in size and shape. You see the prominent cell in the center field with abnormal mitosis here. Look, this is pathological or abnormal mitosis. So if we look the difference between benign and malignant tumors under microscope, we can see the pattern of benign tumors usually resembles the tissue of origin quite closely, quite very similar to normal tissue. In malignant tumors, we often see poor resemblance of tissue of origin. У меня лекция. Also, we see that in case of benign tumor, you see the retained basal polarity, and in case of malignant one, you see the loss of such polarity. Cell atypia or pleomorphism usually not present in case of benign tumors, and it is often present in case of malignancy. Nuclear cytoplasmic ratio in case of benign tumor similar to normal tissue, and in case of malignant tumor it is increased. Hyperchromatism in benign tumors is absent and present in case of malignant tumor. Mitosis may be present, but always they are typical mitosis. And in case of malignant tumors, the mitotic figures increased and are generally atypical and abnormal. Growth rate usually slow in case of benign tumors and rapid in case of malignant tumors. Benign tumors often compresses the surrounding tissues without invading or infiltrating these tissues. And malignant tumors usually infiltrate and invade the adjacent tissue. And metastases are absent in case of benign tumors and frequently present in case of malignancy. Here you see the picture of metastatic cascade. The schematic illustration of the sequential steps involved in the heterogeneous spread of the tumor. So here you see on the top of this picture, transformed cell, then goes clonal expansion, growth of the cells, angiogenesis, you see the new vessel formation, and then you see due to progression the formation of variant cell clones, and one clone is the metastatic subclone. This subclone of the malignant cells has the high opportunity to metastasize. So we see the adhesion to and invasion of basement membrane, then goes passage through extracellular matrix, then goes invasion. Then we see within the vessel interaction with host lymphoid cells. Then we see tumor cell embolus, then adhesion to basement membrane, then extravasation. So cells, these neoplastic cells, go out of the vessel, and we see the metastatic tumor formation in the other area of the human body. So this was a primary tumor. Then with progression we got the transformed cell and metastatic subclone, which goes to vessel, and by blood it travels via blood circulation to the other area, to the other organ, for example lung or liver. Then we see the adhesion to the basal membrane, then extravasation and metastatic deposit. We see the angiogenesis, so new vessels, growth of the new vessels, and at the end the growth of other tumor. So here you see the picture of the secondary carcinoma of the lung. The arrow shows you the foci of metastasis in the lung. The primary tumor in that particular case was a breast carcinoma, and then metastasis to lung. Secondary tumor in the liver. There are multiple secondaries in both right and left lobes and in caudate lobe. The primary tumor was bronchogenic carcinoma of the lung. Here you see so-called Krakenberg tumor. Both ovaries, uterus, ovaries, and tubes. So both ovaries are fairly symmetrically enlarged and replaced by secondary adenocarcinoma. So we see here secondary tumors due to metastasis of the stomach cancer. Please remember these names, Krakenberg tumors. Here you see the secondary melanoma in the small intestine. This had resulted in intestinal obstruction. But look, you see mucosa, the folders on mucosa, intestinal mucosa. And here you see the nodule with a dark color of the surface due to pigment accumulations. And you know that the name of such pigment is melanin. Here you see secondary medullary carcinoma of the thyroid gland in the liver. This lady had a medullary carcinoma of the thyroid removed 21 years before she presented with Cushing syndrome, 3 months before her death. This demonstrates two of the other features of medullary carcinoma. One, that it grows slowly and metastasizes may not appear until many years after removal of the primary tumor. Two, it is one of the tumors that produces ACTH, and the clinical presentation may occur because of the effects of this. Here you see the secondary carcinoma in the lumbar vertebra. Cream-colored homogeneous deposit can be seen in each vertebral body, the biggest being in the lower one. The primary tumor was a bronchogenic carcinoma of the lung. Under microscope, we see here metastasis of adenocarcinoma of the stomach to the lymph node. The tissue of the lymph node is replaced by atypical glandular structures. Here under number 1, you see here these atypical glandular structures, and on the top, you see the lymphocytes left in the lymph nodes. Higher magnification of the same picture. You see stomach cancer metastasis to liver, and you see a lot of the atypical glands. Here on the right you see some hepatocytes, and on the left you see atypical glands formed by cells with enlarged hyperchromic, atypical cells with hyperchromatic nuclei, sometimes nucleolysin. You see pleomorphism, lack of polarity, and you see that all these cells invade adjacent tissues. So here you see the stomach cancer metastasis to liver. The tumors are classified according to histogenetic principles, with the account of their morphological structure, localization, peculiarity of their structure in a definite organ, and benign or malignant character. So various features are the base of the nomenclature. The classification was suggested as an international one by the Committee on Tumor Nomenclature of the International Anti-Cancer Union. According to this classification, there are 7 groups of tumors, and their total number exceeds 200. So you must know main group of tumors. Epithelial tumors without specific localization, we call it non-organ specific tumors. Tumors of endocrine and exocrine glands, as well as epithelial, integument, or organ-specific tumors. Then we have the mesenchymal tumors, tumors of melanin-forming or melanin-producing tissue, tumors of nervous system and brain membranes, tumors of blood system, and teratomas. Let's start with epithelial tumors. Benign epithelial tumors. Benign epithelial tumors are subdivided according to their origin from different types of epithelium into the tumors of intergumentary epitheliums or papillomas, tumors of glandular epithelium, adenomas. Papilloma has following features. It is benign tumor. The origin connected with skin or mucous membranes. It looks like a ledge or bush of branching papilla. Exophytic tumor, slow growth. The base of the tumor consists of connective tissue containing blood vessels. It is a continuation of subepithelial connective tissue covered with epithelium-like layers. So, papilloma-like fingers, they have protrusions covered by epithelium, and in the center we see the stroma, connective tissue stroma. Here you see the villus papilloma of the rectum. These polyps are sessile, soft on palpation, and cover quite a large area. They carry a high risk of developing carcinoma. This particular kind of villus papilloma. Here you see benign tubular adenomatous polyps in the colon. These were asymptomatic ones. As I already showed you, you see the multiple benign adenomatous gastric polyps, and it is an incidental postmortem finding. This picture has already shown to you. Juvenile polyp, this was removed via colonoscopy. These polyps are characterized by the presence of greatly dilated mucous glands, which can be seen on its surface. Here you see the tubular adenoma removed via colonoscope. This polyp was causing rectal bleeding from the ulcer of its surface. Colon polyposis. In the descending part of the colon, there are many protruding structures in the lumen, like tiny fingers, you see. They are on long or short, wide base. So you see this severe polyposis of the colon. Adenoma. You must know what is it, adenoma. Adenoma, its structure is similar to that of the original organ, which is the cause of their functional similarity. So, like ability of adenoma cells to produce some secretes. So, in case of adenoma mucous membrane, they can produce mucus. Adenomas of eosinophilic cell of anterior lobe of pituitary gland can produce somatotropic hormone. Medulla layer of adrenal gland can produce noradrenaline. Beta cells of pancreas, insulin, etc. Adenomas have a typical structure, so tissue atypia. For example, absence of ducts, variety of shape, size, and location. We see different parenchyma and stroma ratio, for example, in case of fibroadenoma or adenofibroma. So various ratio of such tissue. We see variation in glandular tubules and vesicles. In some adenomas, glandular cavities are widened and form large cavities. Also, we see cysts filled with serous fluid or mucus. These cyst-like adenomas are called cystadenomas. Sometimes epithelial growth is so intensive that the papillae invade the walls of the cysts, involve the peritoneum, produce metastasis, relapse, cause cachexia, and may cause severe consequences. These adenomas are termed papillary adenocytomas. They may develop in ovaries, thyroid gland. Adenocytomas may become malignant more frequently than the other adenomas. So adenomas may be found in breast, thyroid gland, liver, ovaries, prostatic gland, gastrointestinal tract. According to histology, they may be tubular and alveolar. In tubular adenoma, there are glandular cavities resembling tubes in the connective tissue with vessels. In alveolar adenoma, numerous bubbles bedded with cylindrical or cubic epithelium are observed in connective tissue with vessels. Here you see the tubular adenoma, a lot of tubules in colon, and the tumor is built of closely adjacent round or convoluted glands formed by hardly differentiated, or other words, mature epithelium cells with the large number of goblet cells. Here you see goblet cells. The stroma is poorly developed. Here between the tubules you see stroma. Stroma contains fine thin-walled vessels and lymphoid infiltrates. So you see dark cells. These are lymphoid cells, and these small, tiny microvessels, dilated microvessels. So here you see the sequence of events in case of adenoma and adenoma formation followed by carcinoma. So here you see the normal colon, then mucosa at risk in case of inactivation of normal alleles, so-called second hit. Then the proto-oncogene mutation. Then we see the loss of cancer suppressor genes. Then more severe mutations and gross chromosomal alteration of many genes, and in that case we see carcinoma. You have already seen this picture, stage by stage, the growth of the tumor from the stage A to stage D. Malignant epithelial tumors or cancers, they can be divided into three groups according to their maturation or differentiation. Well differentiated carcinomas could be squamous cell with keratinization, squamous cell carcinoma without keratinization, and adenocarcinoma, trabecular, alveolar, papillary, and mucous adenocarcinoma. Poorly differentiated small cell or large cell medulla, scarce solid carcinomas, and also we recognize special kinds of carcinomas. Chorion epithelioma, chorion carcinoma, seminoma, hyperenephroid cancer. So here you see the adenocarcinoma of the ileum. The patient had recurrent attack of abdominal pain and finally came to laparotomy because of acute intestinal obstruction. The obstruction was caused by lodging of a large fruit seed at the site of partial obstruction caused by carcinoma. You see here the seed and also the tumor. So it helped to produce the total obstruction of the ileum. And intestinal obstruction occurs later in small bowel carcinomas than in large bowel carcinomas because the bowel contents are more liquid in the small intestine. Here you see the polypoid adenocarcinoma of the colon. When a carcinoma appears at this young age, it is necessary to exclude the presence of some pre-malignant conditions. For example, polyposis, there was no such history of in this case. Here you see another picture of adenocarcinoma. This tumor is partly polypoid, but it had encircled the bowel wall and caused the obstruction. Here you see the adenocarcinoma of the rectum. These tumors frequently present at an early stage in their development with rectal bleeding. Squamous cell carcinoma of the anus, because here you see the origin is squamous cell epithelium of the anus. Carcinoma of the gallbladder, a large calculus is present in the gallbladder. Tumor has extended into the adjacent liver. Here you see the invasive growth of the carcinoma, and on the top right of the picture, and here you see the liver tissue. Adenocarcinoma arising from the bile ducts in the porta hepatis. Here you see the growth of the tumor, the invasive growth, and here you see the liver tissue here. The patient died from the effects of obstructive jaundice. Adenocarcinoma of the kidney. Here you see the kidney, cut surface of the kidney, and the area of the tumor, so-called Gravet's tumor. There is a well-circumscribed spherical tumor, 30 millimeter diameter, bulging through the cortical surface of the kidney. Its cut surface is a bright yellow color. It shows solids areas, cystic areas, and some areas of hemorrhages. Transitional cell carcinoma of the renal pelvis. Here, look, this tumor. You see a lot of papillas on the surface, so papilliferous appearance of the tumor. Transitional cell carcinoma of the ureter. It caused obstruction and the ureter proximal to the tumor has become somewhat dilated. Here you see the dilation due to tumor. Carcinoma of the bladder. The entire mucous surface is replaced by a transitional cell carcinoma. It has caused obstruction with bilateral hydroureter and hydronephrosis. Carcinoma of the left breast. A small lump was palpable, and when the hands were raised above the head, tethering to the skin was accentuated. Carcinoma of the breast lump removed from the frozen section. When cut across, it was hard and gritty, and the cut surface bulged inwards. Again, carcinoma of the breast, a larger lump. Here you see the organ complex, you see uterus, and also you see you can see the ovaries with tubes. So here the advanced squamous carcinoma of the cervix. The pan-hysterectomy specimen shows that the cervix has been completely eroded by a malignant neoplasm. And you see here the invasive growth, which helps to make right diagnosis. Carcinoma in situ plus early invasive squamous carcinoma of the cervix. Here, look, the cervix is eroded. The diagnosis was made on Papi-Nicolau smear and then followed by biopsy. Adenocarcinoma of endometrium. There is a large, rather ragged masses of tissue filling the endometrial cavity. Squamous cell carcinoma of the floor of the mouth. This cancer was removed surgically and the patient lived for another 10 years before dying of unrelated conditions. Here you see the squamous cell carcinoma of the buccal mucosa. We see here the Indian patient from Bombay. Cancer of this type is very common in all cultures where betel nut is cured. Squamous cell carcinoma of the lower third of the esophagus. Again, esophagus with squamous cell carcinoma. Squamous cell carcinoma of the middle third of esophagus, eroding into the left main bronchus. Squamous cell carcinoma of the hypopharynx. Here you see the patchy pattern, some hemorrhages, and also some areas whitish coloring. Under microscope, we see squamous cell carcinoma here. You see the invasive growth. Also, you can see the hyperchromatic nuclear polymorphism or pleomorphism, and also the lymphocytes infiltration of the stroma as a reaction for neoplasia. Here you see again squamous cell carcinoma, only high magnification, pleomorphism, quite common, hyperchromatism, and giant cells with many nuclei. Invasive adenocarcinoma, I have already showed you this picture. Adenocarcinoma of the stomach, and you see here the poor differentiated adenocarcinoma. So you see the atypical glandular structures of various sizes and shapes constructed from atypical polymorphic cells, here under number 1. The nuclei are large and hyperchromatic. Serous carcinoma of gastrointestinal tract. Again, look at the invasive growth of atypical cells with big hyperchromatic nuclei. Diffuse stomach cancer. Look, here you see the stomach, and the wall of the stomach is diffusely thickened in all parts, everywhere. The cut shows that it is infiltrated with gray pink dense tissue. The mucous membrane is uneven. It folds are of different thickness. The serous membrane is thickened, dense, and pumping. The lumen of the stomach is narrowed. Under microscope, here you see the adenocarcinoma metastasis to the lymph node. I have already showed you that picture and higher magnification. So, the most often tumors in case of gastric carcinoma, according to location, we see cancers in pyloric area, lesser curvature of the stomach, then cardiac gastric carcinoma, greater curvature of the stomach, fundal gastric carcinoma, and total gastric carcinoma. The most often tumors in case of gastric carcinoma, we see papillary, mucoid, trabecular, well-differentiated adenocarcinoma. Also, we can see signet ring cell carcinoma, serous carcinoma, solid carcinoma. All these are poorly differentiated cancers. We can diagnose squamous cell carcinoma and adenosquamous carcinoma. In lung, we see exophytic or endophytic growth, type of growth, with superficial spreading time, polypoid, endobronchial diffusely spreading type, nodular type, branching type, and nodular branching types. Here you see the cancer of sigmoid colon, adenocarcinoma of the colon, the invasive growth of atypical cells and glands, squamous cell carcinoma of the larynx. Again, we see larynx, arrow shows the cancer. Bronchogenic carcinoma in lung, you see the invasive growth of the tumor. Alveolar cell carcinoma of the lung, you see multiple rounded red masses of tumor which have developed in all lobes of the lung. This picture have already shown. You see the secondary carcinoma of the lung, squamous cell carcinoma of the tongue, squamous cell carcinoma of the lower lip. This picture I have already shown you, polypoid adenocarcinoma of the stomach, and also you have already seen it, the adenocarcinoma of the stomach and secondary changes like ulceration. Again, this is limitius plastic or sciras, the type of the adenocarcinoma, when the tumor cell infiltrate beneath the mucosa and produce marked fibrosis and thickening of the stomach wall. Here you see early cancer, and I have already showed you the adenocarcinoma of ileum with obstruction, adenocarcinoma of cecum, colon, transverse colon carcinoma, rectum, carcinoma of anus, bladder, again I'm showing you again, bile duct carcinoma, kidney, transitional cell carcinoma, ureter, showing you again, carcinoma of the bladder, uterus, you see here, you see the cervix carcinoma, early stage adenocarcinoma of endometrium, Krakenbeck tumor, remember the metastasis from stomach. And that's all for today. Thank you very much for your attention.